This video was originally recorded during the PalChase webinar on implementing palliative care in protracted humanitarian crisis settings on July 21st, 2021. In this video, Rachel Yantzi, Nurse Activity Manager and Pediatric Palliative Care Implementer for MSF in Goyalmara Hospital, Bangladesh, discusses the challenges and successes in implementing palliative care in this setting.
Provide a little bit of background on the Rohingya refugee crisis here in Bangladesh. So as some of you know, the region in the southeast corner of Bangladesh in Cox's Bazar is where we're located. Back in 2017 was when the majority of the refugees came from Myanmar, but there was actually a pretty large population of Rohingya people living here prior to that. There's currently nearly 1 million Rohingya refugees in this area. We are located near Camp 16, which is partway up the map there. This is just a brief summary of some of the projects that MSF is running here in Bangladesh. Our project is called Goyalmara Hospital, and we also support Inchiprang Primary Healthcare Center. So this is just some photos of our hospital. So at Goyalmara, we have the highest level of care in the area, actually, for neonatology and for pediatrics. We have a neonatal intensive care unit and pediatric intensive care unit. And the need for palliative care in this hospital is very clear when you look at the mortality rate. Unfortunately, the mortality rate in our neonatology department in NICU in the critical care section is often between 15 and 20%, and sometimes around 10 to 15% in PICU. So there's a large number of patients, unfortunately, who don't survive to discharge. And so we're trying to work to improve the care we provide to those patients. So just a brief summary of sort of the implementation. I've been here in Bangladesh since end of October, and I'll be here until the end of August. The work on palliative care started before my arrival, and Catherine and Saqib were involved in that work. The initial efforts here were very focused on, especially around end-of-life care, and we are currently trying to expand that program to include a broader range of patients that would benefit from palliative care. We really are benefiting from a recent release of guidelines from MSF Barcelona that have been useful for our teams. I'm the nursing activities manager with this palliative care focus. And so that prioritization by the operations has really made it possible to move forward, I think. Some of our activities have included between March and currently, we're doing this research study looking at staff experiences and moral distress. We've also been doing meetings with Rohingya community health workers to try to understand some community perceptions and preferred things that should happen around a time of death. We've identified a palliative care coordinator from our health promotion team, who's a very dynamic young man who is eager to learn and has really taken this on as his passion project, I would say. So it's been lovely working with him. And then we have identified nursing, mental health, and medical doctor focal points to advocate among the staff. The process of medication procurement, as Saqib alluded to, particularly morphine, has been extremely challenging. I'll speak more about that later, but that's been a large part of our work as well. And then developing care pathways so that it's clear a process for when we identify a patient who needs palliative care and what happens after that point. We're working on both formal, like classroom type trainings, as well as in-service mentoring and training around developing care plans for patients who have palliative care needs. So I just want to share a few sort of challenges and things that we're noticing, I guess, as we implement this program. One is that, as Saqib mentioned, palliative care in this context is very much conceptualized in a negative way. And I don't necessarily mean only bad, but as in removing of care. So the staff, when I ask them to talk about what does palliative care mean to you, they often refer to it's care when you have nothing left to do for the patient, when the patient is incurable and there's nothing else to do. And also this idea of stopping certain aspects of care. So they don't see it as adding something to the patient's care, but subtracting, if that makes sense. So not giving oxygen, not feeding the patient, not starting IV, new IV cannulas. So, and at the same time, I think all doctors and nurses, but especially in this context, I've noticed really feel the need to do something, that you're not a good nurse or doctor unless you're doing something for the patient. And so I feel like there's a bit of a disconnect there if their conceptualization of palliative care is this negative view. So one thing we're working on is focusing on reconceptualizing palliative care as active care, that we're adding something to the care plan of this patient. The other important factor is just the preferences of our caregivers. The Rohingya population in Myanmar had basically no access to formal medical care. So they have very little understanding of like the concept of CPR is basically foreign to most people because they haven't had the opportunity to sort of encounter medical care in the Western sense, I guess. And so there's a very low acceptance of CPR. So we're not in a context where families are pushing to have us not stop resuscitation. It's actually the contrary, where often the staff feels that they would like to offer more aggressive treatment and the families are not accepting that. We also have a lot of families who, if we try to have a realistic conversation about prognosis, often at that point, the family will ask to go home, sometimes moments later. And this is very difficult for the staff because there's also been recently a lot of effort by MSF HQ and operations to try to reduce the number of patients that we have leaving against medical advice. And so I think that they've really internalized this, guilt, I guess, when a patient leaves to go home, that they feel that they've done something wrong. And so we're trying to, again, reframe that as that may be the best choice for this family in certain situations, especially when there's no access to medications for home-based care. There's a lot of guilt associated there. Obviously the issue of very much a lack of experience of opioids. I've been trying to do training these last few weeks with the staff now that we have access, and no one I've talked to, apart from one or two staff, have ever administered anything stronger than tramadol in their career. So it's very much new to them. They, even in a recent case, unfortunately, we had a child with rabies in the project. And even in that case, the doctors were concerned about respiratory depression. They really have very little experience, and some even believe that morphine is illegal in Bangladesh. So, and also the process of obtaining it has been quite difficult. Some of our non-medical staff. So one of the strengths of our project is we have a very robust mental health program, health promotion team, medical translators, so oftentimes in this context, the doctors and nurses actually don't speak the same language, or at least the same dialect as our patients. And so we rely quite heavily on our health promotion and medical translators, but they're often the ones then to actually deliver the news. So they're the ones that have to speak the words to the family, like your child is probably not going to survive this hospitalization. And I think that they often don't have enough training and support to sort of carry the weight of that burden. They also report feeling quite neglected when it comes to training. A lot of the training that's offered is focused on nursing and doctors, and they aren't sometimes prioritized for training. They do report feeling I thought this is a really beautiful quote from one of our health promotion team members, that when the caregivers feel satisfied with the care, they also by consequence feel satisfied. And this person had said, "I found peace as a result of the mother's peace." Quite a few challenges in this context, but obviously COVID-19 has made it quite difficult. We were in the middle of a upsurge of cases again. And so we're actually we're having a break from COVID lockdown for Eid, but starting on Friday, we'll be back in a strict lockdown. And so we've really had to limit the number of participants in trainings to about 6 or 8 participants, which really slows things down and makes it difficult. The other thing is there's a lot of other training priorities. We actually are anticipating, I mentioned at the bottom of the slide that we have a high turnover of staff because periodically the government of Bangladesh does these recruitments for jobs, and they're highly desirable. So we lost over 90% of our midwives a month ago, and we are anticipating in the next month we'll lose more than half of our nurses. So in terms of training, I have to sort of advocate for the importance of palliative care training and how it really touches on a lot of different aspects of nursing care. And then obviously visa renewals and just the challenges of international staff in the project makes it difficult to sort of maintain the continuity. But otherwise, I mean, the staff is quite receptive to the topic, and I might stop there and we can have some discussion if any of you have questions.